There also living donation is another option. So do you want to talk a little bit about that, Dr. Kumar? Who can give a kidney and what does that involve?
Absolutely. Living donation is something that's extremely near and dear to my heart. We all know, or we all have sort of come to realize that we're grateful that we have dialysis for our patients, because without dialysis, our patients will not be able to live compared to heart or liver failure or lung failure. There's no liver, heart, or lung dialysis. But then having been on dialysis, the example you brought up about your patient having to wait 13 years and getting a transplant was the most joyous time. So we know that transplant is the best option for somebody with kidney failure, not only because of quality of life, but it's life-giving. So when you put it in those terms, a transplant is life-giving, how can you not want transplant for all your patients? Now, organs can come from somebody who passed, just like how Dr. Young described and how you can become an organ donor. But that's something that happens in the future. And we don't have enough organs just from the pool of people passing or dying to make that organ available. We know that the best quality organ that we can get is a living kidney organ. The reason it's the best quality is because it's something that is not on ice for too long. It's used immediately, can be matched better to your recipient. We know exactly where it's coming from. Multiple reasons why living donor kidneys are more life-giving than deceased donor kidneys. So if we accept that living donor kidney is the best option, then living donor kidney means it's coming from somebody who's alive, who's got 2 kidneys. And then when you ask Dr. Brown, who can be a living donor? The simple one-line answer is, if you are somebody who wants to be a kidney donor, that's step 1. You do it out of your own free will without any coercion. This is what you want to do for a loved one. This is the legacy that you're leaving behind. Mm-hmm. That's step 1. Step 2 is a medical evaluation process, a surgical evaluation process. And at the end of the day, we're trying to answer one question. We're saying, if we take 1 kidney away from you, will you go through life as well as you would have with 2 kidneys compared to 1 kidney? And if the answer is yes, you will go through life as well with 1 kidney, as best as we can tell, compared to 2 kidneys, then you can be approved to be a living donor. Mm-hmm. Now, between intent to want to donate and the actual donation happening is multiple steps. Step 1 is calling. If you are in the state of Alabama, then you call our number, and I can share that number with you. It's 1-888-822-7892, or you can go to our website, uabmedicine.org/donate a kidney, one word. uabmedicine, that's one word, .org/donate a kidney. Any of those 2 ways, you go and you fill out an online form or call and talk to us, and we'll do a screen. If on the screen it does not appear like you have chronic medical conditions like diabetes, where you will need your own 2 kidneys, then we bring you into clinic for a whole day extensive evaluation where you meet all the teams that are involved in that process. If you then pass all those tests, if you will, you get presented at the committee, and the committee then says, you know what, as best as we can tell, this person can go through life as well with 1 kidney as 2, you can donate. After that approval process is done, is then we start looking to see what kind of match you are for your recipient, what day we can schedule the surgery, and how do we make it all happen. Mm-hmm. So that's sort of a long-winded way of saying, how does one go about being a living kidney donor? Mm-hmm. Dr. Young, would you like to share anything else about that?
The only caveat to say is that going through that process is very long, very in-depth, that we're not going to go and take a kidney out of someone that we have concerns about long-term. Nothing's perfect, but we're going to vet that person very carefully to make sure, as best as humanly possible, that they will still have a good outcome with the kidney that they're left with.
There are two quotes that like come to mind when I hear this. One was Dr. Deedham in my very early days as a trainee here. Dr. Deedham is the one who started our program, and he said, "Our job is getting to a yes. If a donor wants to donate, then our job is helping them get to a yes and not come into it thinking of no."
Mm-hmm.
And the other thing that he and both Dr. Deerhoy would say was, a living donor is somebody that we honor and we roll out the red carpet for. It's our job to make their journey as seamless and as easy as we can make it for them, because they're doing something they don't need to do. So that's a gift, just like our deceased donors, that we tremendously value and are humbled by.
Mm-hmm.
Yeah, and two other points I'd like to make. And one point is that the transplant coordinator who takes care of your loved one who's looking for a kidney is a different transplant coordinator from the one that would help you get through the process of being a donor. So
Absolutely.
you work independently. And the second thing is, just because you express an interest in being a donor doesn't mean that the cops are going to come out and drag you and force you to do it. You get counseling, and you can, if you change your mind, you're allowed to change your mind during the process. So
absolutely, yes.
a lot of steps, and you can always change your mind if your circumstances change.
Absolutely. We always say that until you're put to sleep for the donation process, up until that moment, you can change your mind. And if you do, we will support you.
And we've even had what we call altruistic donors donate kidneys. People who don't have a family member that need or a friend that needs it, but they've seen stories and they're moved to just donate a kidney. A lot of times that happens for children, but we've had altruistic donors who are moved to do this, donate to our pool. And then when we do our best to go through the list to find the best match and person that we can give that great gift to. So even if you don't have a loved one, but are moved to do this, you can be an altruistic donor. But again, as Dr. Kumar said, there's counseling. We vet these people very carefully to make sure that they truly understand what they want to do.
So, Dr. Young, you mentioned the list, and there are a couple of myths about the list. I've had patients who think that the minute they start dialysis, they're listed for transplant. So if you're a dialysis patient, how do you go about getting on the list? And then we're going to talk a little bit about how, once a kidney becomes available, how is someone chosen from the list?
Sure.
Why don't we start with, how does someone get on the list to get a kidney?
Sure. Once you're diagnosed with kidney disease, obviously you'll be working with your nephrologist, your kidney doctor, who's going to manage you, and then take care of your dialysis, take care of your medications. But that is the person who will then refer you to our center for evaluation. So your nephrologist has to go through all your records, look at you, and determine when it's a good time for you to be seen by us. Once you get that referral, it goes through a process, and eventually you come into clinic where there's lots more tests, lots more people to see. And then after we get all the testing done and you're seen by medicine docs, surgeons, social workers, pharmacists, everybody under the sun, you are then presented in conference where more people will discuss you and determine whether or not you need more things done. There's some people who have heart disease, especially diabetics, who may need more testing, because we don't want someone to have a heart attack on the table or afterwards. We do very well with that. Sometimes they need more studies to determine if they're suitable, or if they have a disease like lupus. If they're having a hard time with lupus and they're on a lot of steroids and they're not doing so well, they need to get better until we can put a kidney in them. So that's why it takes the surgeons, the nephrologists, everybody to determine when someone is suitable to be listed. But it's a committee. It's a lot of group of people that do this together. It's not just one person who just said yes, no, yes, no, yes, no, but everybody has a say.
And then, Dr. Kumar, once you're on the list, I remember I've had a couple of patients ask me, what number am I? So once you get on the list, what determines whether you get an organ?
Absolutely. It's a very, very important question, and we get that question a lot, don't we? So once you get on the list, you wait. And what are you waiting for? You're waiting for that organ to become available. That is when your chances come. Now, how does that work? So the list is run by first blood type. A donor has to pass, and we have to say they're now a deceased donor, and we look at their blood type, and then we look at the people on our list that are in that same blood group. It's a complex process because a kidney that becomes available from a donor in our region has a high likelihood of staying with us, but also can be sent somewhere else in the country. It depends on what the characteristic of the other people on the list in the nation are. Certain patients that are extremely hard to match, or if they're very young, the kidneys can get shared within your region of states around you, or they can get shared nationally. But if a kidney stays within our state, then the first step is to say, let's just say somebody has a blood type of A. So all the patients in blood type A, they're ranked order from number 1 to number, let's just say 500, wherever they're on the list. And if you joined the list yesterday and you're a blood type A, you're number 500, it's going to be the number 1 that comes up in the match run for that person. Now, patients ask us, hey, I was a number 501 yesterday. A transplant happened at UAB, so am I number 500? Well, it all depends on what blood group that particular organ went to. Your number may move if it's in your blood group. It may not move if it's not in your blood group. There are other things that decide if the rank order, if you will. It's how many antibodies somebody has. If somebody needs more than one organ, they get preference. If it's a child, they get preference. So there's a number of things that decide that. In other words, it's a fluid thing. What we do know is for every blood type, there is an average wait time. We're very proud to share that at UAB, our wait times have improved over the last few years. And our blood type AB waits 2 to 3 years. Dr. Young, check me on that. Mm-hmm. Blood type A, similar. Blood type O and B that used to wait 7 to 10 years will always become more like 5 to 6 years. Blood type B still ends up waiting the longest. It's sort of a small portion of the list, but the Black population has a lot of blood type B representation. And as we know, we have a very large Black population, so our list is enriched with blood type B patients, and there are not as many donors that are blood type B to help that. But I would love for Dr. Young to add to that, because this is something that he has to he thinks about every day when he's on call for accepting organs, about rank order and stuff.
Yeah, as Dr. Kumar mentioned, we have an extremely large African-American population. African Americans, I guess, in the state, a little bit less than 30%, but they make up half the list, maybe a little bit more. So if you're making up half the list, but you're only 30% of the population, and then we don't have as many minority donors, and the B blood group is more common in African Americans and other minorities, then it's harder for them to get kidney. And so that's why organ donation, both living and deceased, is so important, because minorities tend to wait longer just because of the numbers. They just aren't there. If I remember offhand, B blood type is around 11-12%, and minorities, where in the general population it may be around 3-4%. And so if you have the vast majority or the bigger percentage, 60%, 70% roughly, of organ donors being Caucasian, it's going to be harder to get those B blood types. Years ago, I was on a committee at our with our national organization that looked to try to improve that. And there's a subset of A blood type that acts like an O. I know it sounds a little bit complicated, but it was one way we were able to get more kidneys to B blood type recipients. So we look for ways, but there's only so many things we could do based on biology. So that was one thing that we were able to change at a national level to increase the availability of kidneys for minorities. But the biggest way to do it is through organ donation and having people sign up on their organ card with the heart and just discuss it among their family. And don't be afraid to ask. Call the Legacy of Hope. They are more than willing to talk to you about it. If you have questions, and they'll probably even, with Zoom meetings, if you have a church meeting or whatever, I'm sure that they can set up something to come via Zoom or however they do it, to talk to the folks in your community centers, church, wherever, to discuss this and bring it to the fore. Because by doing so, we can make the community healthier, and make it better for everybody if we're able to do this and get more people off dialysis. The problem is, as Dr. Thornley Brown can state, kidney disease is endemic in the minority population. And it's very sad, but it's something we have to do. We're trying to get primary care better so it's less prevalent, but for now it's there, and it's something that we have to deal with.
Wow, we've touched on a lot of topics. One thing we haven't talked about, and I'd like your comments on this, Dr. Young, is pancreas transplants. I remember I had a patient who, years ago, I recommended that she get evaluated for a kidney and a pancreas. And she was called, and they told her, "We've got a kidney for you and a pancreas." And she was all excited and came to the hospital, and she got her kidney and her pancreas. And then she woke up and she said, "How come you're not giving me any insulin? And how come I'm getting regular sodas on my tray?" And she had no idea what it meant to get a pancreas. So what does it mean to get a pancreas transplant?
Well, the pancreas transplant is restricted to those people that are diagnosed with type 1 diabetes or juvenile onset diabetes. And there's a subset of type 2 diabetes. That's adult onset diabetes. They're different mechanisms as to how their diabetes occurs. One is where the juvenile type, you're just not making the insulin, and type 2 is where you make it, but it's just not working well enough, and your body just doesn't respond to it properly. But there's a subset, I said, of the type 2. We get pretty restrictive because of weight, because it makes it, the operation is a big operation, and we've got to be able to make sure that the patients are able to tolerate the surgery, and having a good body weight is important. But the pancreas produces enzymes that help in digestion, but it also produces insulin. It goes directly into the bloodstream, and we're able to cure their diabetes. They're on the immunosuppressive medications, but they're not taking insulin anymore. And the problem with the diabetes is, as most folks know, it causes a lot of problems with the eyes, with their heart, all types of things when the sugar's too high. So with the pancreas transplant, and those select patients, they have to be in good shape, we can cure their diabetes. So it's a blessing to be able to do that. It's a bigger operation than a kidney transplant, but we've been able to help a lot of people with that, and we've been able to show that we have excellent outcomes in African Americans compared to Caucasians. There were a lot of studies that said, no, that doesn't happen. African Americans don't do as well, but at our institution, we proved that they can have equivalent outcomes.
So yeah, for a certain group of diabetics, the pancreas transplant is a real blessing. Well, we've discussed a lot of topics today, and I really appreciate the time that both of you have given us. Do you have any parting words? Let's start with Dr. Kumar and then Dr. Young. Any parting words or any other things that we neglected to mention?
Not at all. This was actually very informative and enjoyable event for me, Dr. Thornley Brown. I just wanted to make a plug for our minority population to think about the possibility of kidney donation. There are more Black patients in the state of Alabama on dialysis than any other race. So out of the 8,500 dialysis patients in the state, about 5,500 or 65% are Black, and our wait list reflects the dialysis population of the state. Our wait list is about 68% Black, and similarly, more Black patients are actually transplanted in the state of Alabama. At about 56% of all the total transplants in Alabama But the rate of donation in Blacks is very low, at only 22% of all donated kidneys being of Black race. And if you look at just the living donor, it's only 17% of all all donors at UAB being Black. So this tells us that organ donation, there's a need for organ donation in the Black population. One of the barriers might be because a big part of kidney disease is familial, and even if Black donors came forward and they wanted to donate, they may not be medically safe to donate. So these numbers don't capture all those people that did actually come forward and wanted to. But if you are thinking about doing it, we really want to urge you to come forward, because if you're found suitable, you're saving a life. That's the life of somebody else. If you have a medical condition that needs attention, then you know what? It's been picked up now earlier than we would have done otherwise. And it's still a life saved and a life made better, and it happens to be you. And so I see a lot of value both ways for encouraging everybody to consider being a living donor, and if not, really looking for that heart, that sticker on your driver's license.
And before we get to you, Dr. Young, and your closing comments, one thing we did not talk about is HIV positive people.
Absolutely.
And, do you want to talk a little bit, Dr. Kumar, about the HIV donation program?
Absolutely. This is extremely important. It's being led by one of our nephrologists, Dr. Mehta at UAB, and our surgeon, Dr. Locke. And there was a time where HIV transplants in the recipients, so patients who had HIV, who had kidney failure, who were on dialysis, transplant was thought to be harmful than helpful. But with modern innovations in immunosuppression and, more importantly, good HIV medications, we found that we can actually transplant HIV positive patients, and they do better than if they remained on dialysis. They live longer and they have healthier lives. But we still need organs. And there is a national program now of patients who themselves were HIV, who passed away, who could have been organ donors, that we didn't used to accept before because we didn't want to pass that HIV on to somebody who's not infected. Well, now we can take organs from patients who have HIV, who passed, and give them to patients who have HIV recipients who are in need for a kidney transplant. And this is now being done under a national umbrella, and the preliminary data on this is that the organs do very well compared to patients from organs that come from non-HIV donors. So these were organs that we were not using, that were essentially being thrown away, if you will, and that are now have a new purpose. Similar to the HIV story is the hepatitis C story. Hepatitis C now has fantastic antiviral treatment that cures the hepatitis C, and it's revolutionized a whole pool of organ donors that we would otherwise not have considered. Now they can donate to patients who actually are hepatitis C negative. These patients get the organ, then get on treatment, and they eradicate the virus, and they have excellent outcomes. And most of these organs come from very high quality donors because they're typically much younger subset of groups. So I think those are the two things that are important to touch on. Thank you for asking that, Dr. Thornley Brown.
Yeah, I tell you, when you talk about the legacy of hope, I mean, hope has become bigger and bigger, and there's so many options now that when I first came to UAB were not available. So a lot of exciting things. Dr. Young, you have the last word.
Well, once again, thank you so much for having us to discuss this. What I would love for people to take from this discussion is that we at UAB care about patients. We care about you. We care about your family. We care about your loved one. And we wouldn't do this if we didn't care about folks. And as you can see, UAB is cutting edge. We are here and dedicated to making sure that we can improve the lives of our patients, but also improve the lives of their families. And if you have any questions or there's something bugging you, you're not sure, reach out, ask, call the Legacy of Hope, talk to your nephrologist. You can come. Our organ center, our surgeons, everybody at the UAB Transplant Center is more than happy to answer questions. And if you're just not sure, call, ask. But I just want you to know that we're here for you. We're here to dispel the myths that sometimes are pervasive in the minority community. But we have people here that are dedicated to making sure that you're educated, that you can understand that we do this because we care about people and we want to make their lives better. There are lots of other things we could do. We do organ donors 2, 3, 4, 5 o'clock in the morning, but we do it because we know that we're going to improve somebody's life. And that's our sacrifice in order to help somebody else. But we do that because we care about people, and the people at the Legacy of Hope are there right beside us, helping us and supporting us so that we can get those life-saving organs. So if you have a question, or if you've been fortunate enough and that you are going to be an organ donor, please speak to your family so that they know your wishes. And again, if there's any questions, please contact the Legacy of Hope.
Dr. Kumar, Dr. Young, thank you so much for taking time out of your busy schedule to participate in today's panel. I've learned a lot, and I'm sure our listeners have learned a lot as well. Thank you.
You're welcome. Thank you.
Thank you. The pleasure is ours for sure. Thank you for having us.